Sindra, and I'm a speech-language pathologist in the southern Minnesota area and the owner and operator of FEESability. I've been specially trained in endoscopic swallowing evaluations, and I provide mobile instrumental swallowing evaluations to skilled nursing and other healthcare facilities in the area. I'm also a doctoral student in clinical speech-language pathology, and when I'm not evaluating swallowing problems, I keep busy working on my doctoral research project, which is focused on swallowing problems, otherwise known as dysphagia. Did you know that instrumental swallowing assessments are critical to accurate diagnosis and effective treatment of dysphagia? A recent article in the British Medical Journal reported that in 241 patients with various neurological diseases, following a clinical bedside swallowing assessment alone, that dysphagia was misjudged in 70% of patients. Why? Because no one has X-ray vision, and we can't accurately evaluate something we can't see. Swallowing is no exception. In southern Minnesota, video swallow studies are primarily used when instrumental swallowing evaluations are needed. Video swallow studies are like an X-ray video that records as you swallow. Foods are laced with barium, so they show up on the X-ray. There's a standard food lineup for this study, which includes liquids, sometimes thickened if needed, applesauce, pudding, and a Lorna Doone cookie frosted with barium paste. When these barium-laced foods are placed in the mouth, they can be seen and followed all the way through the pharynx and into the upper esophagus. Here's what a normal video swallow would look like. And here is a very easy to detect aspiration event. Video swallow studies are excellent and can tell a lot about swallowing problems. I frequently conduct video swallow studies and I love them, but they do have some drawbacks. Patients in skilled nursing facilities need transportation to a hospital or clinic because video swallows can only be done in a radiology suite. Because there's a lot to coordinate, this means video swallow studies are difficult to schedule, and often the soonest appointments are several days or even weeks out. Another drawback is that only the barium-laced foods that the patients eat are going to show up on the video swallow study. So secretions and reflux contents that may be causing swallowing difficulties or aspiration do not show up well in the X-ray video. Also, because there is exposure to radiation with a video swallow, to minimize it, only brief video clips are recorded. And so it's not uncommon to miss important details because the X-ray was off when something interesting happened. Patients with cognitive impairments, obesity, or positioning challenges may have difficulty following directions, or fitting or sitting well in the radiology chair. Along with the speech-language pathologist, a trained radiologist, and expensive equipment are needed during the video swallow study, making the video swallow procedure quite expensive. Since the 1980s, we've been doing instrumental swallowing studies basically the same way. Most of healthcare technology has seen significant advances since then. So what about instrumental swallow studies? Is there a better way? Yes. In many cases, using FEES, or flexible endoscopic evaluation of swallowing, is a better alternative. With new endoscopic technology, we can place a small lighted endoscope, the size of a spaghetti noodle, through the floor of the nose and position it to look down at the larynx. This bypasses the area that stimulates the gag reflex, so most patients tolerate this well and can eat a whole meal with the endoscope in place without difficulty. But is this an evidence-based practice? What does the research say? In professional publications, FEES has been identified as the new first choice method for studying swallowing disorders and was found to correlate well with the video swallow results for pathology such as aspiration and pharyngeal residue. FEES can reliably answer all the common questions healthcare providers have about dysphagia. Is this patient a choking risk? Are they silently aspirating? How much and how often are they aspirating? What food textures are better and which are worse? Are thin liquids okay? Can they swallow their pills whole or should they be crushed? FEES can tell you all this and even more. Unlike a video swallow, with FEES the mucosal laryngeal tissues can be visualized. This answers questions about possible trauma after intubation. Maybe there's a vocal cord granuloma. Or maybe patients feel a lump in their throat or think things are sticking in their throat. If swollen tissue or a foreign body is present, we'll be able to see it clearly with FEES. Do you have patients that have difficulty managing their secretions? Secretions aren't laced with barium, so they don't show up on a video swallow study, but they are easily seen with FEES. Swallowing can be affected by esophageal problems, kind of like your sink. If there's a clog in the gooseneck, the problem will back up into the sink bowl. Swallowing problems that are related to esophageal disturbances, such as reflux or GERD, can be seen with FEES. Sometimes we can see reflux happening in real time. But if not, we can usually see the result of swollen pharyngeal tissue due to the chronic exposure of the acidic reflux in the throat. Maybe you have a patient who's NPO, receiving enteral feeding at your facility that you would like to wean from their PEG tube and transition to oral feeding. How do you know this is safe? You sure wouldn't want to schedule routine video swallow studies due to the expense and high radiation exposure. This is where FEES comes in. FEES is easy, inexpensive, well tolerated, and is safe to do as often as needed to ensure patients safely transition to oral diets, significantly reducing their risk of aspiration pneumonia. Because there are no time constraints during a FEES exam, we can assess several food textures, look at how a patient's favorite foods are tolerated, assess feeding fatigue, and try various compensatory strategies like a head turn or a chin tuck to determine if these strategies are helpful. I bet you're thinking of a patient right now in your facility that might benefit from FEES. So give me a call, or text, or email, and let's get started with flexible endoscopic swallowing evaluations in your facility. I'd love to answer your questions or talk with you about how FEES can help the patients in your facility. If FEES is new in your facility, I'm happy to schedule a free demonstration and work with your billing and administration staff to get up and going. For more information or to schedule an appointment, call, text, or email me, or you can visit my website at feasibility.net for more information. And with just a few clicks, you can schedule an appointment. Let's get started, because it's feasible.